STED stands for Spine, Technology, Education, and the D is multifunctional. It's discussion, discovery, debate, discourse, etc. At the end of this academic year, at the end of this calendar year, on December 20th, we have a particularly cool topic, literally a highlight session. We're going to talk about spine stability, this very controversial, effusive term. And I'm going to introduce the speakers in greater detail later. But we have with us online our dear friend, Dr. Zorika Boozer, who is in New York. Right, Zorika? Good morning.
Yeah. Good morning.
She has multiple functions, but she's the director of research and director of the regenerative medicine program at the Gerling Institute in New York. And she's also an academically appointed assistant professor at NYU. She has an MBA and she's multiply published. She's been a steering committee member of AO Spine and co-chairs the NAS section on biologics and basic research. With us here in person is Dr. John Hipp. He's a PhD and a biomedical engineer, and he is actually the founder of a company that has, for years, I think even for decades almost, produced objective measurement tools for spinal stability and has been intimately involved in the assessment and approvals process for certain devices. So, Dr. Hipp, it's an honor to have you here. And with us online is also Dr. Trevor Grieco. He's a PhD in mechanical engineering from the University of Tennessee. And he's been with the same company for a while. And this company is taking some new steps forward in terms of trying to automate the assessment of stability of the spine. And as mentioned, spinal stability has been used as a helpful tool to try to understand pain and symptoms of patients and also assess remediative therapies that we as surgeons apply. So without much further ado, today is December 20th. I want to really thank Dr. Cliff Pierre, who's been awesome in organizing us 5 cases today. And we'll go through them a little bit faster. And some of the cases have been already assessed by the company Medical Metrics, so we can kind of see what some of the objective parameters that this company has developed would look like if we apply it to the therapies we do. And Dr. Pierre is going to take the lead, and he's going to automatically win the Best Dressed Award. So thanks, Cliff, for putting this together so nicely.
My name is Cliff Pierre. I am one of the neurosurgery research spine fellows here this year. And I'd like to get started. As Dr. Chapman said, we're going to present 5 rapid cases. And then we're going to save a little bit of time after Dr. Hipp's talk to kind of apply some of the objective metrics. I'd like to first get started. A 65-year-old female that we've been following in clinic had presented to us with worsening progressive low back pain. Pain radiated into her right buttocks, as well as her right thigh, and she also had bilateral radicular pain for the last 6 months. She had undergone some PT and other conservative management. She says the pain is worse when she walks about a half a mile. She's a highly active 65-year-old. She's plays tennis, pickleball, as well as enjoys hikes. She did note some increased urinary frequency, but denied any bowel or bladder dysfunction. Her exam, she was intact, motor and sensory, and no issues with her reflexes. This is just an overview of the past conservative management options that she has tried. And then now we proceed to some imaging. This is an MRI of her lumbar spine. Here we can note a grade 1 anterior listhesis at L3 on L4. You'll appreciate shortly here a severe spinal canal stenosis, as well as bilateral facet hypertrophy. You can also see some disc degenerative changes at L4 and L5.
So let me interrupt here. So this is a nice intro. Thank you, Cliff. And can you tell us on that sagittal, if you go back to the mid-sagittal, what this, what this wavy stuff is on the sagittal view right above CSB? What is that?
Some of the wavy stuff that you note here at the site of the greatest compression above it is just some of the roots, the spinal roots. So the cauda equina is just right above that. So that's where it's bunches up above that L3 level.
So this is actually flow turbulence. So this is partly actually wavy rootlets, but it also shows that there's a significant loss of hydraulic continuity. So that's a big deal. So Zorica, Dr. Boozer. Zorica, can you unmute? I see you, we see you, but we can't hear you. Yeah, if we stay with this lumbar spine, let me hear that you, first of all, can speak. Can you say something?
Can you hear me?
Yes, now we can. And Alexis, I think we need to go into webinar. We're in practice mode.
So here you can appreciate
So this,
imaging.
yeah. So let me just ask, Zorica, you're also chairwoman of biologics and regenerative medicine. This is a ubiquitous problem that we have. This is a 65, right, Cliff?
Yep,
Year old
65-year-old.
professional. She is a picture of health. We don't want to divulge the profession, but assume this is a highly intelligent, highly health conscientious, very active, socially, work-wise, family-wise person. And her lumbar spine is degenerating at multiple levels. And her looks defy the appearance of her spine. What is going on, and why do we see this so commonly? Are there genetic factors, lifestyle factors, nutritional things? Why is this such a common problem? Is this just a fait accompli due to aging?
Yeah, I think that's a very tricky one, and there is no one answer to the problem. Certainly, and I think, unfortunately, we've all been raised that spine pathologies, degenerative disc disease is because we age, and as we get older, spine degenerates. But we are seeing more and more in very active and younger individuals having degenerative changes that are not necessarily just because of aging. In this particular individual, of course, it's 65, it's a multi-level degeneration. This is just a snapshot of time. It would be great to know how long this patient had spine problems and what caused it. Certainly, it can be genetics. There have been studies showing strong correlation with a couple of genes, but I think it's a mix. And what we've seen as well is adjacent segment degeneration. So depending with the lumbar spine, obviously with biomechanics, when potentially it can happen that when one level degenerates, it changes biomechanical loading, and it can potentially contribute to changes in the upper and lower segments. With this one, it's tough. It's probably a mix. Again, it's an active person, so I don't know her course of prior care with this patient. When was the initial course started, and conservative, but potentially because of being active, it has delayed the care itself, just because patient potentially was able to sustain more.
So if I may be so facetious, at the Gerling Institute, from your answer, which was pretty circuitous, I gather that the Gerling Institute does not have a miracle stem cell product that you can inject into the discs and re-inflate them, correct?
Well, I don't think we have enough time to discuss that topic in general when it comes. I don't. I have actually a question back for you. Do you believe that we can regenerate the disc, or just maybe silence and pause degeneration? I am not sure that. Personally, I don't think that we have any evidence outside of labs that we can regenerate the disc. I do what I believe we can hopefully do, and not in a patient who has multiple level degeneration. I do rather think that maybe if it's an early stage of degeneration, we can pause I don't think we can regenerate for various reasons.
I agree, but let me ask you a very gender-specific thing, if you don't mind going back again. So this is a multi-level problem. There seems to be a difference in terms of the wear and tear patterns of men and women that I have seen, at least in my practice. Men seem to have a more multi-level hypertrophic osteoarthropathy, meaning facet joint overgrowth pattern with large syndesmophyte formations. In female patients, what I see more is this drying out of discs, and the discs become brittle and wobble around more. Is that a fair generalization?
I have seen a couple of studies that have looked at gender differences in spine degenerative patterns and tried to contribute to childbirth, age, occupation. I don't remember if there is anything that ties it back to biology itself and either genetic or molecular traits. Maybe I just don't have the literature on that, but I have seen differences. And then in addition, sometimes there is obviously osteoporosis, arthritis itself that can contribute to differences.
So let me ask Dr. Majid, Pakistan, can you unmute yourself? And then Dr. Shonard also in Puyallup, Washington. What should we do? I mean, this is an extremely functional, very intelligent patient. She's 65 years young. She's had 8 months of non-surgical care. She has been in denial about back symptoms for a long time. Now she can't walk anymore. She has a high-grade stenosis at L3-4, and I'm going to go to the instability with Doctors Hipp and Grieco in a second, because they have done some cool things with this case. What should we do in this patient? What would you do? Do you do a pan treatment because the whole lumbar spine is degenerative? Professor Majid, can you unmute yourself? Otherwise, we'll go to Dr. Shonard. Sahil, can you unmute yourself? Yes, Sahil, what would you do? First of all, salam.
Yeah,
Hi, good to see you.
How are you?
Good, thank you.
Okay. This is a case which we generally see most of the times in our practice. And my personal view is that though there is a gender difference, and smoking and other consumption of other alcoholic things also contributes to the rapid degeneration of such patients. As far as the management is concerned, though she is a very active female and she is very intelligent and is carrying on with her life very nicely, and this must be one of the reasons which is limiting her activities. So in that case, it's very important to address the problem, and she has been having the problem for the last 6 to 8 months, and she has not had much relief with conservative therapy. Now, have we tried any sort of an epidural steroids or something?
Yeah, of
If
course.
that has been
So 8 months, assume that you can't make this patient fitter. You can see her subcutaneous fat is absent. She does yoga. She does a daily ritual. She's a professional. She can't walk anymore. She simply can stand only for a short period of time. She's, of course, had epidural steroids. And assume also that this person has great insights in medical health care and actually reads studies. So there's a certain degree of nihilism towards steroids, but assume that steroids have been given several times with very brief results.
Oh, all right. Now, if we look at the image which is projected right now, the canal is very, very narrow, and we don't expect any improvement in such cases beyond this time. In that case, we should be thinking in terms of a surgical intervention. And currently, an XLIF sort of a thing would be helpful in managing this level. Because since she has multiple level stenosis, we should not, I'm not in favor of going for an all-out attack on the whole of the lumbar spine. So if we address this level and see if she improves, and maybe with the posterior decompression also, and that would be a sort of a mid-path sort of a regime to address these patients.
So
we have
go ahead.
sort of a mid-path regime. And doing an XLIF at one level and a posterior decompression, and see how she behaves. And we have experience of such cases who have been doing well with a limited approach of an XLIF at one level and a posterior decompression with instrumentation.
And do you plate that XLIF? Would you put a fixation screw in there to hold it in place?
We put 4 screws in the back.
Okay. All right. Neil, so thank you for that. You heard the story, very, very fit person, very knowledgeable, reads the literature, not interested in a fusion. Is that the only option? She has this, and we're going to go there next, Dr. Grieco and Dr. Hipp. Is this the right thing to do, to fuse her because she has some instability at that one level? She clearly has a high-grade stenosis. She's failed everything non-surgically. This is your dream patient, except she reads too much.
Yes. Yeah, and her questions are piercing, and her humor probably makes the whole day very enjoyable. So I want to agree with 2 things that were mentioned by the previous speakers. Number one, this is single-level disease when looked at from an operative indications perspective. Number 2, biology and genetics are of academic interest, but don't enter into the clinical decision-making for both this single level disease and for the multiple level disease above and below, because that has not, at least out in the community, that has not evolved to the point of a reliable treatment option. So yes, Jens, the surgical indications for this, she fulfills nicely, and she happens to be an ideal candidate with none of the comorbidities that are associated with risk. And her fundamental problem can be significantly impacted and improved with relatively low risk. So that's my concluding remark.
So what are you going to do? Here, Dr. Cliff has put down a nice thing. She's done everything on the top. She can't be more fit. You're going to operate. So are you going to do a decompression, decompression fusion?
Yeah. So there are options on that. So you can do indirect work from an anterior approach. It just depends upon where your skill sets are. If your skill sets are an anterior approach, you can do OLIF, XLIF. You'll get indirect decompression of that central stenosis and the neuroforaminal stenosis. If you have experience with that. If you don't have experience with that, a posterior approach will accomplish the same goal with the use of direct decompression. Whichever is in your wheelhouse, that's what you should do.
So, by the way, I want to make a little pitch for Dr. Schonert. He was one of our faculty at the 9th Annual Spine Trauma Summit that we just concluded this weekend, and I do encourage everybody online to look at his great lecture on vertebroplasty. He actually has a sensational lecture that everybody wants copies of on how he changed the federal payer thing from Medicare in the US with early vertebroplasty. It's an amazing clinical accomplishment in terms of doing a state-of-the-art research. Thank you, Neil, and congratulations on that great research that you presented.
You are kind, my friend.
No, you are kind. Recommended. Dr. Askuyan has arrived here. He's our chief of spine, and you're a master of XLIF. So I've heard XLIF, far lateral, it's called far lateral approaches, isolated for 3-4. Is this a good idea in a patient with multi-level degenerative disease? Can you get a good decompression? Can you get enough fixation?
I think it's a reasonable approach. I didn't see the
flexion extension.
Can we see 4-5, and then do we have flexion extension?
Of course we do.
We do.
Yeah.
Cliff has done.
I mean,
yeah.
I think it's tough because as everyone sort of reviewed here, she's kind of has a little bit of multi-level disease, 3-4 being the worst level. I think it's a reasonable approach to consider doing lateral. Yeah.
Yeah. Here's the flexion extension stuff, and We'll talk about stability in a second, and Dr. Hipp and Dr. Grieco are both itching to make their statements. Okay, so let's move forward what we did, and then let's talk about stability.
So for our patient, we proceeded with a L3-4 microdiscectomy laminotomies with the interlaminar spacer device that was performed. These are her intraoperative images. These are her dynamic images immediately post-op, flexion extension and neutral. And then this is delayed post-op about 6 months after her treatment. She had an unremarkable post-operative course. Her last clinic visit, she was asymptomatic with respect to her symptoms. and she's doing quite well and still staying active with PT exercises and using a recumbent bite and doing some squat exercises.
Dr. Grieco, do you want to show us a little bit what you think about stability? So this is an interlaminar stabilization device. This patient, again, had done her reading, and she did not want a fusion. She was very clear about that. I'm not sure whether I fully agree with it, but I do agree that she needs a decompression and some form of a stabilization. I would have been unhappy to just decompress her. Do you want to talk about stability right now?
We could.
Yeah, sure. Happy to chime in here. So if we look at, we have the preoperative images pulled up here again. This patient had a grade 1 anterior listhesis up there, and you can see the motion data. We analyzed this imaging. So at L3, L4, there was 6 degrees of angular motion, about 5% end plate with translational motion, which is not a lot of sliding. It's less than 3 millimeters. And we have these novel indices, which John is going to speak more on later, but it doesn't look like there's gross instability here from a motion perspective between flexion extension. We have to acknowledge the fact that when you go in to do the decompression, right, we could always introduce some type of instability. So that has to be taken into consideration. The fact that the patient did not want to deal with a fusion makes sense that there was some alternative intervention there with the spacer. But initially, right, here's the post-op imaging, and we see really just stable motion, not a lot of motion at L3, L4. What you're looking at is the stabilized imaging where we have effectively frozen L4 in place between flexion extension, which enables you to visualize motion at L3, L4 quite clearly compared to a side-by-side flexion extension. And all the motion's quantified again. If we look at the metrics preoperatively to postoperatively, we see that there is increased stability, actually. So some of our metrics will demonstrate the move towards very normal motion with the utilization of this implant. And I think the post-op delayed case is also very interesting to show. Like Cliff show that perhaps, and kind of talk about how this patient is progressing with their motion profile and their instability. But it is, it's a really unique case, and it's great to hear that she's doing well so far. We see that the spacer has provided some stability. Her symptoms are relieved based on what everybody has said here. And our analysis demonstrates postoperatively that initially there is a stable joint there.
But there's more motion now, isn't there, than there was initially? So there's some loosening. The spine is claiming, again, I resected about 50% of the joint inner surfaces. I left the capsules intact, but the interspinous ligament obviously gets sacrificed in this procedure. So where's this motion coming from now?
Yeah, so this is really interesting, and I believe this was a couple months later, correct?
This is 8 months and 9 months later, right, Cliff?
Yes.
Yeah.
Right. So if you kind of compare the motion, if you look at the spacer, and the stabilization really helps visualize this, you see that implant moving, inferiorly, kind of into the spinous process, it would seem, here in this delayed imaging. And the motion has changed a lot since our initial post-op, right? So these FIST index and this ADW index, which once again, John will describe more in detail, have gone from close to 0 to above 2, which basically indicates that they are above the upper limits of normal with regards to their coupled motion. So we are seeing a progression towards instability many months later here. And a lot of that is directly related to how the implant appears to be behaving. You can see it once again, it appears to be subsiding in extension there, or settling, perhaps is a better word, into that spinous process where it's been implanted. And if you flip back once again, just to really appreciate, I think, the difference in motion here, look at how stable the implant is right now. It's just flexing like it's supposed to, really, right? Between, it's L4 is frozen here. and the implant's just flexing up and down, and you have this stable motion. Then flip back again, to the delayed motion, and look how the implant's moving, right? And we have a lot more motion, and the amount of translation as well as the changes in disc height with respect to the angular motion that's happening in this pattern outside of normal limits now. What does that mean clinically? I think research still needs to be done really to get to that answer. But this motion profile has progressed into.
Go look at the. I'm a speaker at this.
Neil, were you going to say something? You're unmuted. You said something.
Oh yeah. And so I wanted to comment that the post-operative films are easier for me to see on screen than the pre-op films. The post-op films, by my read, show both coronal and sagittal listhesis. So my alarm bells are going off big time.
Yeah. I mean, so far
the device is being placed already in a compromised clinical scenario. So you're asking a whole lot of an interspinous device in this scenario.
And this is a very astute observation. When I started using these devices, and I have no conflict of interest with this company, I just always looked at some alternatives to fusions, and I'm a fan of doing just decompressions only. But there's this middle ground of somewhat unstable spines where if I did a decompression, they would start slipping. Dr. Robert Huang, thank you for joining us today. He made the astute observation, why not just decompression? I've frequently, in these grade 1 spondylolisthesis that are, quote, relatively stable, done this, and I still don't know all the parameters. And this is part of this talk today is, do we have a more sophisticated way to understand and quantify instability to see how treatments work? To be very clear, when I started using these, I used these devices only in very elderly or compromised patients, and I've expanded more to active people, but maybe this patient is too active. Yeah. This patient does play pickleball again. She does run, she does her yoga, and I don't even want to see what she does with her spine, but I think her pain scores are literally absent, like zero. And ODIs are normal, literally like in the single-digit range. So let's go to the next case. But spinal stability is exactly this in quantifying this. And again, aging is cruel, and we'll see how this device is doing. But Dr. Grieco picked up that there's some instability evolving. So we're not done with this patient. Next case.
Next case is a 18-year-old gentleman, active athlete, plays basketball and tennis, presenting to our clinic with axial bilateral back pain for greater than a year. His pain is exacerbated by increased activity, denies any bladder or bowel dysfunction, has a normal neurological exam. Just notes that he has some decrease in his activities due to his pain, so he's not able to stay as active in his sports. He underwent 16 weeks of physical therapy just to manage his symptoms. This is an MRI of his lumbar spine. Axial and sagittal views, T2 images. You'll notice a high-grade spondylolisthesis at 5'1", with some severe foraminal narrowing at that 5'1" junction.
That's beautiful how you present that. Can you go through the sagittals, also show the foramina?
Yep.
So again, this is a high school athlete who has collegiate, in a high-profile sport, I don't want to mention it, who has collegiate scholarship ambitions. And this is obviously an isthmic spondylolisthesis, and we can see flexion extension films in a second, so the foramina are heavily compromised. This is an amazing athlete, totally fit. If you look at the psoas shadows, each psoas is larger than a vertebra. Dr. Garrett Lewick is going to show, not today, but at a different time, the prospective value of determining psoas size relative to vertebral bodies for muscle health. And this is flexion extension. And again, we have a high-grade spondylolisthesis. Tariq, Dr. Sohail from Lahore, Pakistan, what can you tell us about this? How heavily, how do you grade this? And if we talk about surgery, again, this patient is very stoic, does not have overt neurologic deficits. Parents are healthcare providers. everybody has been concerned about the spondylolisthesis, and he does a collision sport. I don't want to go into the details here with possible college. So how high would you go? Would you consider surgery? Would you let this guy play a collision sport? Tariq.
Well, I think thank you very much for asking. I think it's probably developmental because the dome is fairly, but the S1 is very domish, and I think it's not new, but I think it is a progressive spondylolisthesis at L5-1. I don't think so. It's unstable, but I think there is certain degree of impingement of the L5S1 level, and there is also degeneration L4-5 level, which probably will I think it will progress because there's also a disc bulge there at that level, and if he carries on his pursuit of the high level collision games, probably might get worse over the period of time. I think what I would suggest is symptom is good enough. I would just fuse L5, L4, 5, and S1. S1, I little do an old-fashioned in situ fusion from the S1 to L5 with the DHS reman and putting a fibula graft or some kind of graft there, which is very effective, and it gives you opportunity to decompress the root and also to stabilize the situation in situ. At the same time, it will allow the fusion to take place and carry on his activity subsequently without any. And it's a simpler procedure rather than trying to reduce it and doing a sort of a dome osteotomy at the S1 level. And I think I would just stabilize the L4-5, nothing bone carpentry to be done at that level.
So the difference in the US is if we fuse them to 4-5, and this is a common problem in these higher grade isthmic spondylolisthesis patients, that patient will never be cleared to do contact sports again. If we manage to do a fusion at 5-1 alone, the patient could, if everything goes well, return to unencumbered sports. Dr. Grieco, Dr. Hipp, have you had a chance to look at this case stability-wise?
Yeah.
Go ahead, John.
Show what we did?
Yeah.
Okay.
So we'll show you what we did. And again, Cliff.
Okay, so we proceeded to, again, just keep our surgery at the 5-1 level where we did a laminectomy 5-1 as well as an intradiscal osteotomy and fusion from L5 to S2. Here's our intraoperative images. We have intervertebral spreaders into that disc space after clearing it all out. We have placement of our screws as well as rods to reduce the 5-1 level. And then we placed interbody expandable cages bilaterally. Again, we freed up all the nerve root. We were careful while placing the cages to not cause any injury to the L5 nerve root as well. And so this is the immediate postoperative films. And just the CT lumbar spine of our hardware. Again, no unexpected surgical changes. And for the sake of time, I'm just going to proceed with, again, the delayed imaging. And then I'll bring up the images that our group from Medical Metrics was able to include.
So Medical Metrics has a technology to measure vertebral stability very objectively. And again, we'll defer to Dr. Grieco here to tell us how unstable this obviously displaced spine is, number one, and number two, the L4-5 question, because L4-5 is used as a compensatory segment to overcome the significant displacement at L5S1. So Dr. Grieco, tell us what your stability assessment of the spine tells us.
Right, so in this scenario, we didn't actually analyze S1 here, but you can see in the stabilized imaging that there's no motion between L5 and S1, right? So L5 is frozen in place there, and S1 is not moving. Obviously, there's a gross listhesis here, and from an alignment perspective, that cannot be ignored. But there's no mobility at the joint, as exhibited by this flexion extension stabilized imaging right here. And if you look above it, once again, there's not There's also not a ton of motion at 4-5. I mean, most of the motion in this flexion extension exam is happening at L1, L2, L2, L3. So not a lot of motion to actually look at as far as dynamic instability goes in this scenario. And fast forwarding here, right, to the postoperative case, this is obviously appears to be solid, fusion. There's no motion at this time point right here. I'm not assessing any bridging bone or anything, but as far as mobility goes, the listhesis has been reduced somewhat, of course, and we're locked in at L5, S1. The motion, superior motion at 4-5, appears stable by our metrics right now in this imaging, anyways, and similarly in this imaging.
So two technical points here. So first of all, it's a great discussion. Again, in our assessment, just using our crude assessment skills, 4-5 looked stable and worthwhile. Preserving the disc health was pretty good looking. We'll obviously have to see how that does in the future, and by realigning the spine anatomically, hopefully there's less of a shear factor. Two questions. Dr. Askuyan, as a surgeon, Dr. Kulkarni has suggested, why not do a minimally invasive L5 S1 TPLIF?
I think for a grade 2, grade 3, I think it's going to be very hard to reduce this through an MIS approach. So I think you got to do open surgery, especially in someone young. So.
And then Dr. David Christensen asked the question, and this is a common question for us, what about an anterior reduction and fusion ALIF?
I think it'll be very hard to reduce this, and you saw it didn't move on flexion extension x-ray, so I think you're going to run into difficulty reducing it from the front, and then the angle, I think it'll be difficult to get in the inner space.
I think what Dr. Tarek Sohail said was very important. This is a dysplastic variant of an isthmic spondy. So the pars in the backside is literally skewering the L5 root, and it's not very possible to kind of get that reduced. But I mean, I'm always happy to see that. I have a large revision practice, and I see a fair number of failed fusions. So I'm always happy to see what works and what doesn't. In my hands, I see more failures of attempts at trying to do an ALIF with an isthmic spondy, but sometimes it works. I mean, I'm not going to say that doesn't work. Clearly, an in situ fusion is possible. And again, Dr. Kulkarni, thank you for sending us a reference. We'll try to post that. Alexis, can you post Dr. Kulkarni's case report for a novel technique for reduction? In terms of minimally invasive, this incision was 5 finger breadths long. The patient, I think, was in the hospital for a day or two. Pain for the incision was not a problem. So not sure what we gain with less invasiveness, but in terms of soft tissue dissection, that's obviously become a strong mantra. Dr. Neil Patel is next. Thank you, Cliff, for nice cases. Neil, what case have you selected?
I've selected a young patient, 55-year-old, she's a physician by profession, very active, low BMI, doing really well, again, health conscious. She presented to us at age 55. She was intact on her exam, except had some foot drop on the left side. We got an EMG that showed acute on chronic left L5 radiculopathy, no peroneal nerve involvement at that time, and had nothing pertinent on the lab. She had tried other physical therapy, medical management, etc. And because of this acute on chronic radic, we decided to get images. So this is the L-spine MRI. Again, kind of going through that area, L3-4, and then this is L4-5. And side to side again, foraminals, looking for foraminal sources. This is the left side is the side of that's affected. And her nerve roots had some good CSF around the nerve roots in the foramens, but there was some lateral recess stenosis, we thought, at L4-5, especially where she has no disc at L4-5, bone on bone there. So we proceeded with the EMG findings in her foot drop. And a young patient active, we proceeded with L4-5 LAMI. Here are post-op images. We didn't have pre-op x-rays in the system because this was a while ago, but you could see again a LAMI defect at L4-5 there, post-op. So she did well from that, and she presented, again, she did 10 years of good kind of outcomes. She presented back to us at age 66, again, with some left buttock and lateral aspect of thigh pain, L4-5 kind of distribution. She had tried, again, physical therapy, gabapentin, TENS unit, lidocaine, topical, etc. And this is her new MRI. Now you could see some L3 on 4 spondy, enterosthesis, and I'll show that as a dynamic spondy in a second with flexion extension x-rays. There you can see significant stenosis, facet hypertrophy at the adjacent level. Again, L4-5 is bone on bone, and you could see minor Lamy defect there. There is fluid in the facets, and side to side, again, L3-4 is has foraminal stenosis now as well. She was intact, except her actually left dorsiflexion was pain limited this time. She did have good function. EMG again showed old chronic L5 redic, and no other signs of acute denervation. Everything was chronic at this point. She had tried epidural spinal injections, L5S1 with no relief, and L4-5 with solid relief of the symptoms that she had presented to us with. Her DEXA scan now at age 66 showed osteopenia. She remained in good health and shape and had BMI of 22 and was doing well otherwise actively.
So let me just interrupt you. Zori, Dr. Boozer, from New York, you're the basic sciences expert, both for biologics and for biology here. Can you go back to the mid-sagittal? This is a great case. Nothing hurts follow-up more than follow-up. So great care by Dr. O, this is his patient, and did a beautiful job at 4-5. What happened at 4-5, and now what's going on at 3-4? Is there kind of some common denominator? Is there some logic behind this?
Well, I don't remember now how her paraspinal muscles, but we are also seeing that there are changes not only within the disc, but the muscle as well, the quality. And we've done back at USC studies, we've done kinematic MRI studies where we have found that depending on the quality of paraspinal muscles and the fat infiltration, that they were correlated with disc degeneration. There are many studies that show that. Given that this patient initially had L4-5, probably grade 5 Furman, and then degeneration progressed on the adjacent upper level.
So yeah, I think this is just this weird overload of 4-5, and a nice decompression was done, and then the whole disease, basically the stiffening of 4-5, has led to an instability at 3-4. That's how I see that. Dr. Grieco, is L3-4 unstable now?
Yeah.
Well, I mean, I haven't seen the flexion extension x-rays here, but it looks like there's some fluid in the facets there, which we have studied and correlated to some of our instability metrics. And without having seen the dynamic imaging, I can't really comment on the quality of the motion. But like you said, there's the listhesis here. You see the fluid signal. I'd be curious to get a look at the flexion extension imaging.
Okay. So that's coming next here.
All right.
So this is her images from 11 years ago and now, and again, that instability here. You could see 6 millimeters versus previously there was nothing, and this is where I kind of wanted to get your opinion on. Is there any way you could have predicted from these images? We didn't have FlexX 11 years ago, or at least not in the system that I saw. But if you had this, could you have predicted this outcome now?
Oh, that's a tough question. I mean, we're still studying the predictive capabilities of these metrics. We've seen some early signals that might suggest the ability to predict, future instabilities progressing. But I'd be hard pressed to say that we could definitively have predicted it without looking at the data more closely. There's definitely potential, I think, for biomechanical signals, advances in artificial intelligence, as well as our normative reference data to make us aware of, possibilities that can happen in the future biomechanically. Being able to get a holistic look at the motion across all levels, as well as just the global motion, will all be helpful in creating those predictions. But at this moment, I can't say with any certainty that I would have been able to predict this.
I think this is really good. So let's move forward so we can get to some other
So
cases.
we have the flexion extension here, and as you kind of mentioned, 6 millimeters of range of motion or dynamic instability from flexion extension. Here's a CT scan. Again, this disc was not calcified, did have some facet hypertrophy on the MRI as I had shown. This is the area. You could see some increased spacing in the facets as well.
Great. I would fuse it L3 to 5, but curious to see what you did, Rod.
I mean, this was a difficult decision, but she also had osteopenia, and she really didn't want a fusion.
Previous Lammy D.
So what'd you do?
We did Coflex.
Oh, wow.
Placed a Coflex spacer in, and this is her pre-op and post-op, and we try to stop that dynamic instability at a place where it'd be reasonable for her. And post-op, her pain significantly improved. She did well. Her pain-limited weakness kind of went away, and she was doing well for up to 6 weeks. And of course, as you said, at the 7th week, she kind of presented with some back pain and buttock pain. At this time, we proposed L3-4 fusion.
Clinically, she was doing well.
Yeah.
But, I was worried about her x-rays post-op. And then I had talked to her about doing a fusion. And, it hasn't gotten worse. But I don't think it's going to, long-term, it's going to hold. But she's doing phenomenal right now. So she kind of wants to hold off on doing anything.
So this is a challenge to our basic scientists here. We would so clearly these interspinous process spaces seem to work in some patients, and there's clearly some patients who are too, quote, unstable to make these sensible, and there are people who are stable and they don't need this. So this is a unstable spine. This is a high disc. There's facet joint fluid. But again, for me, one of the biggest problems of outcomes assessments is that neurology trumps stability. So if patients have compromised nerves, they are far more affected adversely in their PROs than patients with instability, usually.
Yep.
So what are we going to do? Just watch her now?
Watch her.
Great.
Yeah, she
I love it.
refuses fusion, so
Good.
she's gonna.
So let's go for another case. Thank you, Neil.
Yeah.
We have a beautiful sunrise here in Seattle, by the way. We can't get our cameras out. Dr. Gautam Rao just came back from Tampa, Florida. These are his last hurrahs here with us. We are all sad to see him go. Gautam's been phenomenal. Thanks for coming back. And here you are on live TV. So another stability issue.
थोड़ा सा फैसल को करवा रहे हैं रैकेट शैकेट हल्का सा अगर स्ट्रेट में कुछ होना ठीक है तो चलते रहो किसी को
Great. Thank you, Dr. Chapman. Happy to be back. Case presentation for today, no relevant disclosures. We have a 57-year-old female, very active, does bicycling, does, I think, pickleball or tennis, some racket sport, and does just overall very healthy individual. She's been kind of complaining of lower back pain for a multitude of years, exacerbated recently by a fall about 4 years ago from greater than 6 feet, as well as a cycling accident where she ended up running head-on into another bicyclist 2 years after that. She presents to our clinic with a lot of low back pain and some radiation to her left groin as the main symptoms. Again, very active, and this is kind of affecting her quality of daily life. What do you?
We can't see the image.
Can't see it.
Yeah, the images with the toxin up. So again, this is a consistent theme. We have, quote, aging patients. I have to be careful because I'm in my early 60s. Alexis is helping us. There's something wrong with the PowerPoint. These are patients in their older years, and they're still wanting to be highly functional. Zorica, from a mechanical standpoint, should we tell older patients to not do certain sports like pickleball? Is pickleball bad for you?
That's a tough one. I think it really depends on how active they were. And any sport can be bad, but at the same time, what I want to ask the panel is, how do we have right patient outcomes to evaluate what is, especially in patients with spondylolisthesis, what's the success and where they need to pause and stop. That is something that I personally struggle, the sensitivity of the outcomes, how we look at them, and then
great
how
question.
we guide patients' treatment.
Yeah. Rod, great question. So do we have the right outcomes parameters? In our system, we actually have fully integrated patient-reported outcomes. So we have ODIs, VASs, opiate scores. We have all sorts of things that are in our daily charts. They're directly integrated. Are we measuring the right things?
I think that's a great question. I think I mean, as we've seen a lot of different variables and enter into that, psychosocial factors, so I think it's variable. I think they're pretty reasonable. But unfortunately, most of the health systems now, there's so many different outcomes that people look at. But I think, for us, I think ODIs in the current, environment, I think is reasonable.
So we don't have great things, Gautam. So we need to get rid of that panel. So
Yeah.
I don't know what happened here. Oh.
I don't know if I can do it on this side.
Alexis, can you get that out? So let's go to this patient. Let's kind of accelerate a little bit. Sorry about this. Let's go to the images. So she's neurologically normal. She's extremely healthy, very active, socially a professional, and voila. What do we see here, Gautam?
We see a grade 1 angiolesthesis at L4, L5 with some severe modic end plate changes causing some moderate to severe canal stenosis at that level. The other vertebral bodies look good. There's slight degeneration at L3-4 as well, but L4, 5 and L2-3 look healthy disc spaces.
So, Zorica, what are modic changes? How does that translate into histology and chemistry? Are there inflammatory mediators in this modic zone?
Yeah, so there has been a lot of research around modic changes, which are the changes within the end plate and bone marrow, and depending on the level of the change and intensity, there is a severity score from modic 1 to 3. Actually, and I think there are now two schools of thought when it comes to low back pain and disc degeneration. Is it discogenic coming from disc, or is it vertebrogenic coming from the end plates and modic changes? And so modic changes have been associated, they contribute to low back pain, accelerate degeneration, instability, obviously changes in the vertebral body, how that impacts the instability. So a lot of research, and there are groups, for example, at UCSF, that are focusing really on that vertebrogenic pain.
So quickly, she was non-mobile on flexion extension
Correct.
films. We're going to bypass that. Hounsfield units, we actually checked her DEXA scan, right?
Yeah, they're good. They're not osteoporotic.
We actually did a DEXA scan also. Yeah. So she has no osteoporosis. Dr. Schonert astutely commented on that. So this is, quote, stable. Is it, Dr. Grieco? Is this stable? I'll return the question.
So you said she was not mobile on flexion extension at all. It's a grade 1 slip. I mean, this goes back to the whole theme of the talk coming up, right? Is what is instability and the challenges of diagnosing that. And I think it's a combination of mobility, of course, as well as alignment. But Without any motion here, right? She doesn't meet a lot of instability criteria, such as, translation, rotation, and so on. So once again, it comes back to the definition of instability, which I think we're all still wrangling with.
Do you have axial images, Dr. Colquhoun?
No, I don't have actually.
Sorry.
It shows us moderate to severe canal stenosis at that level.
So moderately severe central stenosis, as I remember, and severe foraminal stenosis. Rod, this is stable. Yeah. Does this patient actually need a fusion? Does she just need a foraminal decompression? Do the modic changes matter?
I mean, I think, I don't think a decompression is going to work. So I think either you do, I think given the amount of listhesis and the disc degeneration, I think you're going to either have to do fusion or do nothing. So,
all right, show us what we did just in the interest of time, because we want to go to our guest lecturer.
Absolutely, we did L45 TLIF, interdiscal osteotomy and reduction of the spinal listhesis. Here are the intraoperative films. On the left side, you have the preoperative initial baseline film. Next, we have our spreaders, and we're reducing the spondy. As you can see here, we have our screws placed and the good reduction here and the placement of our bilateral TLIF cages. These are the postoperative films, good placement at the lateral edges with good realignment and restoration of height.
So how's she doing now?
She's doing great. Fantastic. Pain's gone. No issues. This is her 3 to 4 month x-ray films postoperatively. No complaints from her.
So was this a reasonable case for a fusion? Would this have possibly been better dealt with a... the cage size, by the way, you have to mute yourself, Dr. Majid. To your question, these are 17 millimeter cages. We put them in at a size, these are expandable, obviously, 10, and then we slowly expand them, and we usually do neuromonitoring and watch the L5 roots. So not any restrictions there. These are these modern cages, and by doing a full release, stability is a question. Neil, in your opinion, can you do better with
a patient who has a good DEXA scan? But in case the patient is osteoporotic, what would be the plan of action?
Probably cemented screws, but if you look at the cages, we put them into the apophyseal ring. So we try to avoid the central depression where the vertebrae are weakest, and by going laterally and using 2 cages, we've actually largely avoided subsidence.
All right. Fine.
So, but she did very well. She returned to everything so far. Yeah. But now the question again in the longer run will be, what will L3-4 do? What will L5-S1 do? This is again where spinal stability is. Dr. Garrett Lewitt prepared a case, but will probably not be able to show that. I'm very sorry. He had a case of a multi-level stenosis, and we did a multi-level decompression on the patient. And we want to look at that. But I'm so sorry, Garrett. But thank you. We had a good discussion. What would you do in Tampa?
I think we do the same thing.
Posterior?
Go posterior. I believe she may have had like a unilateral pars fracture, I think on the left side that may have caused this. But with that amount of disc degeneration, I think the easiest way to make sure you decompress the neural elements is to go posterior, open everything up, and reduce the spondy and fixate it.
Let me ask Dr. Before we go to our guest lecturer, Dr. Hipp, Rod, you're a master of XLIF far lateral surgeries. Is that an advantage to do kind of a MIS? Is it less invasive to go anterior than posterior screw fixation in these kind of cases?
I mean, I think it's reasonable. Here, the iliac crest is a little bit higher, and you always have to worry about the plexus at 4-5. So those are the only 2 downsides.
Would you have done this anteriorly, posteriorly? Is that truly less invasive?
No. I mean, it's still surgery.
Yeah.
So
I mean, this patient was in the hospital, I think, for 2 days, and she went home and started walking, and she's pretty much returned to normal life. She plays tennis and everything. Yep. So
back to normal.
She's actually quite happy. So yeah, so invasiveness is not necessarily the size of the incision. And again, a great discussion in the chat room. Hounsfield units and CTs. I think we're seeing a quantum leap towards CT scans replacing DEXA scans. I totally agree. There'll actually be a paper from one of our fellows, Dr. Fravert, coming out in the near future that does address that. And Dr. Schonert in his study did reflect on bone density measurements and how we probably as surgeons should take greater control of this by using CT scans. Is that right, Neil? You're muted, Neil. Thank you, Gautam. Thank you very much to our fellows, and I apologize to Dr. Lewitt, who is not able to show his case. So it's a great pleasure to have with us here today Dr. John Hipp. As I said earlier, he is the CEO and founder of Medical Metrics, which we all in spine knew for years as a company that basically validated and looked at devices. Alexis here, she's our boss here, and our boss is here today. So thank you for organizing all this. So as a matter of introduction, he in background worked in medical metrics, but he is from the a graduate of the biomedical engineering program at Rensselaer Polytech, and worked in a biomechanics lab in Boston with an appointment at some place called Harvard Medical School. He got a Kappa Delta Award for predicting fracture risk, and he spent 10 years doing spine research at Baylor, which I knew him from, and he did multiple cadaver studies in that area. And he has received the Henry Farfan Award from NAS and has had over 100 papers. And he's been a major name in spinal biomechanics, and his company, again, has kind of become the main go-to corporation that helps assess devices. So it's a great pleasure and honor to have you here in person, Dr. Hipp.
Well, thank you for the opportunity to talk about a subject which has been of great interest to me for a long time. So in a conversation yesterday with Drs. Chapman and Pierre, we identified a bunch of cases that we want to talk about. So I want to breeze through some of the introductory material by describing the reality as this. I can produce for you 2 stacks of research papers. One stack would be essentially summarized by this review. There's a lot of literature on the diagnosis and management of lumbar spinal stenosis, and most all studies will conclude that instability is an important part of deciding whether or not to add fusion to decompression. And of course, these are echoed in professional societies and regulatory authorities. So, here's another one, talking about the importance of spinal instability. So essentially, we've got these 2 stacks of papers. One stack describing instability is really important about deciding whether or not to fuse the patient. Another stack critiquing the criteria that are currently being used to assess instability in clinical practice and in research practice, and also by payers. The conclusion of that stack of papers is that by the current standards we would like to demand for diagnostic tests, there's not a single test out there for lumbar spinal stability that can be considered to have a documented sensitivity, specificity, positive predictive values, all of those metrics that we would like to see. So there isn't a single validated test for instability. So let me just get to so we've got a quandary. We got basically all this literature saying you need to diagnose instability to determine whether or not you should add fusion. There's another stack saying there's no diagnostic test that's validated for instability. So how do we reconcile this quandary? And so, one thing we need to do is again, critique the instability criteria that have been out there. And again, in interest of time, I'm just going to point you to a preprint that we have on Research Square, which does a deep dive into this issues and really critically reviews all of the instability criteria that are out there, but also talks about some of the more novel techniques that I'm going to talk about today, and that you saw some of the metrics already in some of these cases. So basically, is there a better approach to diagnosing spinal instability? If so, One of the things you have to do is account for variability in patient effort. So you can have a patient who's got gross instability, but if they go in for flexion and extension study and they just lean forward a little bit and lean back a little bit, the whole time they've got this big compressive load on their spine, and that compressive load is stabilizing the level, and you will not diagnose instability in a lot of those cases. So you have to account for variability in patient effort and really demand it. The next thing is, if you look at data for healthy spines, there's a big difference, a significant difference in motion at L2, L3, for instance, compared to L4, L5, so you have to account for that. You also need to account for variability in vertebral sizes. You know, there's that criteria that there's 3 millimeters of translation, that means instability, but 3 millimeters of translation may in fact be a clinical problem for a small woman with very small vertebrae. But that same amount of translation would be well within normal limits for an NFL linebacker. The next thing you need is really good, solid reference data that help you decide whether it's normal or abnormal. And we do have data for about 300 plus asymptomatic volunteers. I would say that's not even enough because we really do need to represent all, sexes, both sexes, all races and all ethnicities, and figure out, whether or not we need to tweak the normals. And finally, this all has to be given to you in an easily digestible metric. You don't really want to have this big set of lookup tables that you have to sort through to figure out whether it's normal or abnormal. So we believe there's two candidates that fit all of these requirements. The first is what we call a metric for rotation-dependent translation. And the nice thing about both of these metrics is they can be easily calculated just by putting 4 landmarks on the corners of each vertebral body. And the nice thing is this can all be done now totally automatically with artificial intelligence and machine learning. So once you've got those landmarks in place, you can calculate things like the disc angle and extension and flexion, subtract them, and you got the rotation. Then you can calculate translation in a bunch of different ways, but we recommend really looking at that posterior inferior corner of the superior vertebra and how it's translating with respect to the lower vertebra. The nice thing about that is if you look in healthy spines, there's quite a strong linear correlation between translation and rotation. And note here, we're giving you translation as percent end plate width. And that accounts for the vertebral size. And so take this type of data. So the blue line tells you what is average normal for healthy spines. If you got a patient that's moving basically 10 degrees, got 10 degrees of rotation, and their translation is right at the upper limit of that gray zone is a 95% confidence interval, then we can give you a metric that describes the rotation-dependent translation in that patient and we quantify it by this yellow line, and we describe the magnitude of the yellow line by essentially the standard error of the forecast, which is basically a metric that tells you the variability for any particular amount of rotation. So in this particular case, this would be 2. The units would be 2 standard error of the forecast. And what we like to call this is our fist index. And the reason we call it that is because it seems like this translation would be primarily affecting the foraminal and spinal canal regions. And it's sagittal translation, so it tells you that. So it's how that corner is pounding into the foraminal region in between flexion and extension. So now if you got another patient also who has 10 degrees of rotation, but now their translation is up here at around 12.5%, we would give you that metric and tell you the fist index is 4, and you would know immediately that that amount of translation is very abnormal for that amount of rotation at the particular level you're looking at for the vertebral size that you've got. So it accounts for all that. It's, I think, a pretty useful metric. So here's what normal intervertebral motion looks like. And note we've got pretty good rotation at L4, L5, and L5S1. And the FIST index is well within that normal range, which would be +2 to -2. And so if you look at what's happening, and this again is stabilization. So what we're doing here is holding L5 in a constant position on the display as you flip back and forth between flexion and extension. And it allows you to visualize a relative motion much better. And if you look at the translation that's occurring in that posterior inferior corner of L4, it's really quite small. So what happens in a normal spine is a translation that's occurring is a minimum amount that has to be there in order to provide the rotation that the patient is demanding. The patient doesn't demand translation between the vertebrae. They demand rotation, and the translation is just the minimum that has to occur. So here's an example of abnormal intervertebral motion. And so you can see the FIST index is over 4 at 3.4 and 4.5. And now look at the difference here. Look at the amount of translations occurring between, for instance, L4 and L5. And imagine if there was a nerve root there and what's happening to that nerve root, particularly in extension. There's a lot of dynamic change that's occurring with this abnormal FIST index. Here's another example. Here, the FIST index at 3.4 and 4.5 is very high. L5S1 is 2.5. So clinically, that would tell you that at L5S1 is just above the 95% confidence interval. But again, imagine what's happening to that nerve root in the tissues in that foramen with abnormal FIST. So what does this mean? So basically, the FIST index is relatively new, and we don't have direct data, but let's consider this research from Morishita et al. And what they did is in live patients during open posterior surgery, and these are live patients with spinal stenosis, they would put a transducer in up against the nerve root so you can measure the pressure on the nerve root as you change the position of the patient. They also measured the CMAPs. And so what they conclude is that with changes in position, there's significant changes in the pressure on the nerve root. And with a significant change in the pressure in the nerve root, there's a deterioration of the latency and amplitude of the CMAPs. So this is not direct because we don't have the FIST metrics here, but it certainly does support that abnormal FIST might matter. And here's a companion study they published a few years later using basically the same methods. And what they concluded here is intermittent claudication with spinal stenosis may be greatly affected by the variation in dynamic mechanical stress on the nerve roots. And so again, we think that although we don't have the FIST metrics for these patients, it does support that abnormal FIST might matter. So one thing about a diagnostic test is you would want it to be picking up abnormalities in a population where you would expect them, but you don't want it to be picking up abnormalities where you wouldn't think they would, instability would be found. So at Medical Metrics, we've analyzed thousands and thousands of flexion extension x-rays, so we could pull together almost 8,000 pre-treatment flexion extension lumbar x-rays from a range of different types of treatment studies. And so what we did is we calculated proportion of levels with abnormalities, and we looked at abnormalities that are just over 2, which includes those kind of borderline abnormalities, but also the proportion with FIST index over 3, which represents the more severe instabilities. This is sagittal plane instability. And in fact, the proportion of levels with instability is much higher in patient populations where you would expect it compared to where you would not expect it. And interestingly, there's also adjacent level instability. And you can imagine in some of these studies that might have been important because adjacent level instability may have impacted outcomes down the line and therefore the results of the study. So far we've been talking about this shear instability, but a number of authors and clinicians have talked about the importance of this vertical instability. Basically, in the cranial caudal direction, how much is that upper vertebra hopping up and down on a lower? And with the same landmarks that we can get now automatically, we can calculate the disc height and flexion and extension anteriorly and posteriorly, and calculate the change in the disc height. And in healthy normal spines, there's a very linear relationship between the change in disc height and the amount of rotation. So again, this would be rotation-dependent change in disc height. And we can express that with kind of the same type of metric, where we tell you how far away from average normal the change in disc height is for your particular patient. So here's an example of abnormal ADW. And you can see it's almost 8 at L4, L5. Fist is normal at that level, at basically all the levels. And if you look at rotation is very small, right? So you wouldn't tell from rotation or translation data by themselves that there's any instability in this patient. But the ADW index would tell you there's something really wrong here. And generally what we find with this type of pattern, collapsed disc height, very abnormal ADW, is that the motion seems to be hinging at the facet joint. And normally the center of rotation should be sort of more in the middle of the intervertebral disc. And also we find typically this vacuum sign appearing in extension. So the ADW index, if you want to do a study on vacuum sign, it's a great way of finding vacuum signs. And the prevalence of ADW abnormalities, we did kind of the same experiment with the same pooled data. And in fact, the prevalence of ADW abnormalities is significantly higher in populations where you would expect instability. But also note that ADW abnormalities are much more prevalent than the shear abnormalities. And there's even a higher prevalence of ADW abnormalities in things like disc arthroplasty and biologic disc treatment populations. And also there's ADW abnormalities at adjacent levels, which might prove important. So our recommendations are at this point, to first collect high quality flexion extension x-rays. We've had a lot of clinicians tell us, well, that's just not a reasonable expectation. You really can't do that in a symptomatic patient. But we at Medical Metrics have analyzed a lot of big multi-site clinical trials of stenosis and fusion patients. And in fact, when you look at the data, you'll find sites that are consistently collecting flexion extension studies where you've got like between 8 and 12 degrees of motion at the treatment level. Then you're going to find sites that are collecting flexion extension x-rays consistently with only 1 to 2 degrees, right? So what's the difference between these sites? They're all working with the same inclusion-exclusion criteria. The difference is the protocol that's being enforced at the site. So the sites that say, I need diagnostic quality flexion extension studies, use a protocol, and they get those studies consistently, like 80% of the time. So it can be done. We believe that you should be using just simple rotation and translation metrics with extreme caution because they're very dependent on patient effort and other issues. We think that that fist index might be useful for picking up shear instabilities and the disc widening index for the vertical instabilities, but really more evidence is needed. We do think there's a possibility, and we have a couple clinical trials in progress, but there's a possibility that these metrics might help resolve this long-standing dilemma about how to decide which stenosis patients need fusion. So I thank you for listening to me, and I would like to point out just 2 things quickly. One, we have a great interest in collecting high-quality data, so much so that we're giving out these metrics for free right now. And not only that, but we're giving out research grants. So anybody out there who wants to contribute to the scientific evidence and help determine whether these metrics really mean anything, we welcome collaborations.
Thank you. Can you go back to the slide that shows the plot graph? I think it was number 6 or 7, but I lost count, between rotation and translation. I thought that was a phenomenal resource. I love all your graphics. And yesterday talking, it was a plot diagram. Go back a little more. As you're looking for that, and I'll keep looking with you. The first question I have is, how should we get proper lumbar flexion extension films? A simple question, but your smirk tells me you know where I'm going. So there's a great deal of inconsistency how radiologists obtain flexion extension films. Yeah, that's a great one.
Yeah, so essentially we've got a clinical trial that's pretty much wrapping up in the Netherlands. And what we did for that particular trial, because it's basically a study determining whether the fifth index, which we called SPIS-I in that particular study, could influence treatment decisions. And if you use the abnormal fifth index to figure out whether or not you should do fusion, that was the purpose of the study. So in that particular study, we developed a protocol which essentially uses just a simple walker. So the patient stands in front of the walker. If you turn the walker around so there's a bar in front of their thighs, when you put a bar in front of somebody's thighs, when you ask them to bend forward, they don't bend at the hip joints anymore, right? So it forces the motion. And then you can ask them to go down and grab onto the bottom legs, and you get great flexion. Then an extension, you turn the walker around and you just have them lean back and grab onto the walker. And basically in typical clinical trials at medical metrics, maybe 30% of flexion extension x-rays have at least 5 degrees of rotation at the level that you want to analyze. In that particular study, we're over 80% successful at getting good quality x-rays. So there's a protocol, and the trick was that we had everybody involved, clinician, x-ray techs, and patients, watch the same video. So everybody's kind of on the same page about what needs to be done.
I really like that. And again, this would be one of those things that I would love to have practiced more consistently, at least in our medical community in the US, but maybe internationally, making definitions. Dr. Boozer is very influential in this. Tariq Sohail, you have your hand up. Tariq, thoughts?
Thank you very much. Very interesting studies. But how do you evaluate soft tissue hypertrophy or impingement of the foraminal, area? Because this is what you're showing is a bony element, and what you normally see in the CT scan or X-ray, they are the bony element. But before the bony element creeps in, there are a lot of soft tissue intrusion of the spinal canal or the foramen, and causing various kind of symptoms. How do you assess that?
Well, of course, you have a great point that this is a very limited metric. It's telling you about motion only. So you have to combine that with the information you get from an MRI if you want to understand the influence of all the other factors that you as clinicians have to consider. So we're talking motion only. We're just simple engineers. This is what we can do, but this needs to be integrated with clinical expertise.
Have you done any study where putting interlaminar devices? How do they influence the foraminal area? And this is one of the interlaminar or the interforaminal laminar device. They or interspinous device. They increase the diameter of the foramen. At the same time, they cause kyphosis at the same level. How the studies, whether in minor instability or otherwise, you can explain the mechanism of action, and how do you see that over the period of time this impingement or the derangement or degeneration will progress further or not? In my clinical experience, I have used the central laminar devices, which are made of silicone material. They over the period, I think they deteriorate further. In a 2-3 years time, they come back to the same level of degeneration. What you would expect if what you would expect with the passage of time. Yeah. They
So
are not
most-
a permanent solution to the degeneration. They do halt the progression.
So influence of motion preservation devices, I'd abstract a question like that, and kyphosis or kyphogenic nature of some of them,
Yeah.
and do they adversely affect the biomechanics of adjacent segment discs?
Yeah, and I think it's kind of interesting in that first case that was presented here. If you look at that patient, their preoperative motion at the level where the Coflex was put in, that level had sort of the highest proportion of rotation through the spine. So the patient essentially preoperatively was demanding most of their motion, or a good proportion of their motion, from the level where the Coflex was put in. And you put in the Coflex and you saw what happened immediately. It pretty much stopped motion. But then the body says, well, no, I want to go back to the pattern I had. And what happens is you had, whatever happened, the erosion of the spinous process. The point is, I think it's really multifactorial. I think, the reports that we can provide you with a lot of data, which essentially gives you a biomechanical profile of what's happening in the spine. And I think you need to integrate a number of different variables to figure out maybe what's best for the patient.
If you go forward, so I love this correlation, and for us as clinicians, disc height matters, but rotation and translation are intrinsically woven together. There's clearly a signature, a collagen, viscoelastic signature of a patient that I think we're seeing expressed here. Do you mind going forward to the vertical instability? So one of our fellows, and I just texted him because I still don't see the paper and publication, talked about the vacuum disc. So the vacuum disc in his systematic review is actually something that is probably symptomatic. There was this beautiful video, if you show that again, your animated video. So these vacuum discs are actually, based on the best possible systematic review, symptomatic. How does this figure mathematically? This is clinical observation based upon a synopsis and a meta-analysis of the literature. How does this express itself mathematically? Is that ADW, and how does that get quantified?
Yeah, so this is the change in disc height for the amount of rotation that occurs, corrected for the level that you're assessing, and adjusted for the size of the vertebral body by presenting everything in percent end plate width. So essentially we have, just like that other graph that you saw with a linear relationship between translation and rotation, we can show you the same type of graph for the change in disc height as a function of rotation. And the thing about that is it's even a lot cleaner. The gray zone is much narrower. It's a much more predictable property of a normal healthy spine. And that is what essentially gives us the raw material that fuels the potential of this diagnostic test, which we call the ADW index.
So that's news to me. I look forward to seeing more about that because, again, in our very carefully done systematic review, vacuum discs are a pathologic entity that is highly correlated with adverse patient symptoms. So that was really cool for me to see. Final question. I know we are running out of time. So we've concentrated on the sagittal alignment and instability. Today I have 30 patients in clinic, and I'm pretty sure 10 of them will have degenerative scoliosis, an asymmetric coronal plane lateral ascesis, and eccentric disc collapse. Where are you in medical metrics with quantifying the coronal balance and coronal stability of patients?
Yeah, so that's certainly in our pipeline, and we're making great progress toward giving you those alignment metrics. But when you think through the checklist, if we want to actually quantify lateral instability, we need to develop the clinical tests for it. We need to develop the normative data. So we've got to collect a lot of healthy people doing whatever provocative motion would provoke potential lateral instability, and go through the same effort. And it's absolutely something important because many clinicians like you have told us, you can't ignore that. That's very important.
Yeah. No, thank you so much. Rod, any final comments from your end?
No, I mean, I think, this is really interesting. And I think getting more data and, working with different groups and institutions, as you pointed out, there's lots of variability, but I think it's the future. So
I want to know, I want to take you right down to clinic and install that software into our program. I absolutely want that. This is very cool. My fear is that organizations like in our state, we have a workman's compensation group called L&I, and they want to simplify fusion indications to numbers. So my worry is that this gets abused also, but I want it in my clinic. So please come down, give us a software key to put that in. Final comments, Zorica?
I had a very quick question for John and actually the panel. So what's more important, John and Jens as well, would love to hear from you. We have well-defined, and I agree, metrics and tools to measure instability. So what's more important, having this radiographic metric that is based on AI or relying on pain, a patient-reported outcome of pain with loading? So which one do we trust?
Well, I would certainly say that if you had an abnormal fist index in a person and they're perfectly happy, then you would do nothing, right? It's just like MRI abnormalities. They don't really mean anything unless there's symptoms to go along with it. But my issue with the people who advocate the importance of pain in diagnosing instability is I don't know how you'd standardize that. How exactly, so when a clinician says there's pain on loading, what exactly does that mean? Because I think is going to be like the instability quantification from x-rays. It's going to be very clinician dependent, and if we can find a way of standardizing that, like having a very standardized way of moving a patient and a standardized way of quantifying the pain, then maybe that would work. But at this point, I don't see that in the near future.
Zorica, I'm obviously going to answer with C. It's not A or B, it's C. I want both. So we obviously need to have some quantification to objectively see what's going on. Tariq Sohail said it well. We obviously need to see the soft tissues. For me as a clinician, neurologic impingement, I said it earlier, overrides mechanical instability. Yes, mechanical instability is a factor, but in my clinician judgment, and I totally agree with Rod's solution to his case, which radiography didn't look great, but he helped the patient. Neurology is the first thing that if it's really hit, even very functional patients, our neural systems are geared atavistically towards alarm messaging when there's neurologic compromise. Mechanical instability, yes, that's a factor. Severe misalignment, progressive instability, yes, they're disabling. But neurology trumps. Rod, what do you think?
Yeah, I mean, it's difficult, but I think, fortunately nowadays we've got a lot of different surgical options. So I think trying to focus too much on getting, the rights, like looking x-ray is not always going to be, the end goal in some patients.
We clearly need these kind of measurements. As we're doing fusions, we need to see and understand how this affects other vertebral segments, what motion segments are doomed to fail. The focus on alignment that we've all undergone now has been very good, but again, how much does that actually help patients avoid more surgeries? The predictive value of surgeries is very important. As we're looking at more motion-saving procedures like what we discussed with that Coflex device, we clearly need to see more about how these actually function in various patients under various mechanical loads. So there's a lot to learn, but this is clearly a technology I want in our PAC system this afternoon. Right?
Yeah, absolutely.
Okay, let's go down.
Yeah.
Let's load it. Thank you.